Good evening. Welcome and thank you for attending our Head of Cancer lecture series this evening, sponsored by the Allegheny Health Network's Cancer Institute. My name is Michelle Studnicki, and I am one of the program coordinators for the Cancer Institute. There are a few housekeeping items that we want to review before we start. First, during the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing and discussing those questions at the end of this lecture if time allows. Also, participants are not able to speak during the conference, but again, we encourage the feedback via the chat option. Our topic tonight is Beyond the Scalpel, the high-tech future of cancer surgery. We are very excited to have with us tonight Dr. Patrick Wagner. And I would like to take a moment to introduce you to him and give a glimpse of his outstanding work that he is doing here at the Allegheny Health Network. Dr. Wagner specializes in the surgical treatment of digestive and complex abdominal tumors, including esophageal, gastric, pancreatic, liver, colorectal, and appendix cancers. He cares for patients with metastatic cancer, including liver and peritoneal metastases, as well as patients with rare tumor types such as sarcoma and neuroendocrine tumors. Dr. Wagner serves as the director of the Complex General Surgical Oncology here at the Allegheny Health Network. He received his medical degree from Harvard Medical School in Boston, where he completed his surgical and pathology residencies at the New York Presbyterian Weill Cornell Medical Center in New York, New York. He completed a fellowship in surgical oncology at the University of Pittsburgh Medical Center. Dr. Wagner is certified both by the American Board of Surgery and the American Board of Pathology, and is a fellow of the American College of Surgeons and a member of the Society of Surgical Oncology. He prioritizes patient-centered, individualized care planning in his clinical practice and emphasizes minimally invasive approaches, including robotic surgery whenever possible. Dr. Wagner strives to make innovative treatment options available to patients and complex cancers, translational research, and clinical trials. Welcome, Dr. Wagner. Thank you for joining us.
Okay, thank you, Michelle. Are you able to see me and hear me?
Yes, we are.
Yes, we can see.
Okay, great. Okay, so I'm going to basically tell two short stories this evening about things that we have been piloting here at Allegheny Health Network. And so high tech can mean a lot of different things, but in our world, we think about high tech being technical things that we do differently, like robotic surgery or minimally invasive surgery. But we also think of technology, including innovative ways to find or treat or detect cancers, especially during surgery. So I'm going to talk about two ways that we're sort of leveraging modern technology, especially molecular technology, which you don't necessarily think about in the operating room. But I think we have a unique program here, and we're pushing that forward for patients with digestive cancers primarily. So the first thing that I'll talk to you about is a clinical trial utilizing a type of immunotherapy to try to incite a immune reaction to tumors when they have metastasized to the peritoneal cavity, which we call peritoneal carcinomatosis. And not a lot of people are necessarily visually familiar with what this means, but sometimes organs in the abdominal cavity, like the stomach or the bile ducts or the pancreas or the colon and rectum, the appendix, and especially the ovaries can develop cancers, of course, and those cancers can kind of grow until they have grown all the way through the organ they started in, and then they get out into the space that the organs are floating around in, which we call the peritoneal cavity. And when that happens, it's essentially like a contamination event. The cancer cells can can land wherever they land, and then they can begin to grow and basically spawn new tumors, like what you would see here in the picture, which means that the organ.
Dr. Wagner, we're not seeing your slides.
Oh, you're not? Oh,
No.
I should share them. That would help. Hold on. Thanks for letting me know.
There you go.
Okay. So now you can see it, and now you can picture it. Metastatic cancer nodules that would grow on the surface of organs that are typically smooth lined, but they develop nodules, which is each one of those represents a new growth of cancer, and so it becomes quite difficult to treat this type of cancer. And we typically are going to use a combination of surgery and chemotherapy. And in our hands, we're trying to push immunotherapy forward to help patients with this very difficult problem. So one of the research studies that we have done here is to really study the environment in which the cancer is growing. There's a lot of studies in the past about the environment within different organs, like the colon or intestines shown here. But we have launched a series of studies to really characterize the environment around the organs, not the organs themselves, but the space in between the organs and the space where these tumors land and begin to grow. And you can just see the pictures represented here. On the very left is a schematic of the normal intestines. And in the middle is the carcinomatosis, which I was telling you about, with the nodules of cancer growing. And then in the most extreme cases, fluid begins to build up, and that fluid has cancerous cells in it. That's called ascites. And that's kind of the worst case or end stage situation where we really have big problems for patients because their cancer has grown quite extensively, and it's really beginning to sap nutrition and protein stores for the patients, leading to declines in their health. And ultimately, in many cases, this is kind of what happens towards the end of the course in digestive cancers. So without bogging down too much in the details for tonight's purposes, we embarked on a research study where we took samples of the tissue and the fluid, and the idea was really to look at the immune system markers in this environment and to try to drill down on what potential targets there might be for us as drugs become available to target elements of the immune system, which ones we would pick out and select to try in clinical trials for patients with extensive cancer like this. And again, I don't want to bog down in the details, but we just took a whole bunch of different what we call cytokines, which is essentially, you can think of it like the hormones of the immune system, and just kind of studied the differences in between patients that had cancer and those that did not, patients that were just having surgery for benign reasons. And we found a couple of indicators here right in the middle that were very high in the orange category, which is patients with cancer, and very low in the blue category, which is patients that didn't have cancer. And so that's where we're looking for our targets, is when we have massive differences between those two groups. It tells us that there's something going on in those patients that we should be investigating. And so we focused primarily on these two right in the middle, the big tallest orange bars, which are IL-6 or interleukin 6 and IL-8 or interleukin 8. And we have growing clinical trial platforms to try to inhibit those two immune system hormones to see if that will help patients with cancer at these late stages. Interleukin 6, as I had mentioned, is one of those immune system hormones, and this is all scientific jargon here. But what I really want to indicate is that immune system hormone can drive cancer. It can actually it has properties, or it has effects on cells that can drive cancer to grow faster, to spread faster, to have blood vessels grow into it, and really to favor a poor outcome for patients by driving the cancer. Fortunately, there are drugs, there are available drugs that are FDA approved to block this pathway, one of which is called tocilizumab. And this chemical was initially developed this drug was initially developed to help patients with autoimmune diseases like rheumatoid arthritis, and actually became quite helpful during COVID because it is an immune suppressant. It suppresses that drive that I was telling you about in the immune system. And so for patients that had an overabundant, overreactive response to COVID, which often was the cause of death with COVID, more so than the virus itself, was the overreaction of the body to it. This drug was very useful in suppressing or tamping that down and helping patients. Anyways, it is FDA approved, used on many, many patients in the past to treat immune conditions, autoimmune conditions. And so we have a clinical trial active now to sort of leverage that molecule or that drug as an immunotherapy to try to help patients with malignant fluid around their organs. In the abdominal cavity, as I had shown you before, the same thing can happen in the chest cavity around the lungs. And so we are treating patients with both kinds of metastatic cancers with this FDA-approved drug. It has been used on many patients for many reasons, but it has never been used in this way to be given directly into the body cavities to treat cancer. And so this is an outdated slide. We initially received funding from the Pittsburgh Foundation to treat 12 patients. Based on success and additional funding that we were able to obtain, we've expanded to accrue 24 patients. I think we're close to accruing our 10th patient now, and we'll push through hopefully until we get 24 patients on the study. And not only are we looking to see if it's beneficial in reducing the amount of fluid, but also looking at tons of scientific markers or molecule analysis of what happens to that fluid to see if we can really discern the effects and predict patients in whom it would be helpful for. So a lot of promise on the horizon. We're, a good ways away from finishing the study still, but we've accrued, as I said, almost 10 patients, I think, in about a year and a half. So we're moving along faster and faster. We're accruing at an increasing rate. And we've built a big team around this program to help bring the studies to fruition. And the second way that we are tackling the same problem is actually to inject the tumors themselves. This treatment that I just told you about is a treatment for the fluid, the malignant fluid, around the organs. We're actually had a different clinical trial where we were injecting an immunotherapy drug directly into the tumors to assess whether that was effective in stimulating the immune system. And the way that we ran this trial, which has now been completed, was that we were doing a laparoscopy in patients who were subsequently going to have a much bigger surgery. But sometimes we do a preliminary procedure, which is just a same-day outpatient surgery to do a laparoscopy, just to have a look, take some biopsies, and get the size of what the operation will be that we're looking at. And so that gives us a chance during that laparoscopy to do an injection, for instance, in this case. And then when we go back a couple weeks later to do the big surgery, we're able to harvest those tumors. We would be taking them out anyways. But in this case, instead of just taking them out and sending them off to the pathology department, we actually took them to the research lab. And so we're able to continue to examine those tumors to see what happened when we injected this agent. And this specific agent is called lipopolysaccharide. It's actually a cell wall chemical that's derived from E. coli bacteria. There were no living bacteria in it. It was just kind of a component of the cell wall from the E. coli, or the shell, you might say, of the bacteria, which is very stimulating to the immune system. The immune system, one of its main jobs is to find infections or to react to infections. So our idea really was to capitalize on that, to try to alert the immune system to the cancer, to really light a fire, so to speak, in the cancer to create a response in the immune system. So we were able to treat 12 patients on this protocol and get their tumors after surgery. We also did a separate injection just of saline, kind of as a control or a placebo, if you think about it that way. So for each patient, we have both a placebo and an actually treated tumor, so that we can compare and contrast what happened to those tumors. We're still working on that. It's quite a long process to get all of them testing done in the lab. The patients all did fine from the procedure and from the injections. but we don't have the final results of what happened in the tumors just yet. We're still working on that. This is just a picture taken during surgery, and you can see on the left side there's kind of a slimy nodule right in the middle of the screen. And in the background, you can see the intestines and the liver in the very back. And what you see, that metal thing that you see coming across the screen from the right edge, is actually a needle. And this is a picture taken with laparoscopic surgery, and the needle is in the tumor, and we are injecting the drug at the moment the picture was taken, so you can kind of see it. And on the right side of the screen is just another picture showing the aftermath of where the injections had taken place. And so this is just sort of a summary, but I wanted to show this concept that this is a different kind of high-tech surgery, not necessarily what you would think of with lasers or robotics or minimally invasive techniques, but really harnessing molecular technology and cutting-edge concepts in immunology and immunotherapy to try to make ourselves smarter during surgery, not just the knives and sutures and conventional concept, but really can we change the environment that the tumors are growing in as surgeons to try to improve outcomes for our patients. So that's an exciting set of studies. We have several additional studies that are on the horizon, one of which is to inject, it's like this study, but to inject a virus, a cancer-killing virus that also stimulates the immune system directly into tumors. That's underway now. And then in the future, we will actually, I'm just going to go back a few slides just for purposes of illustration, take the fluid like you see around the organs, which we call ascites, or pleural fluid if it's in the chest, drain that fluid and get the immune cells separated from the fluid, and then stimulate them offline in the laboratory to really make them hyper-reactive, or to stir up a hornet's nest of the immune cells, and then to give those cells back to patients in a different setting under circumstances that make them more likely to attack the cancer cells. The fact is, cancer cells have evolved ways to avoid destruction by the immune system, but we can take them into the lab and reverse that to try to override the suppression that the cancer has wrought on the immune cells, and turn that around and try to give it back to patients. So that's our program at the moment, and we have a growing number of protocols kind of month by month are coming online. So an exciting time at Allegheny Health Network. This program, is brand new over the past couple of years, and really gaining a lot of momentum and a lot of notoriety, and hopefully being able to start offering new options. We have not really offered patients with this type of cancer anything substantially new in decades. We just haven't found anything yet that works better. So we're really, really hopeful that we can begin to turn the tide there as we learn more about the immune system. All right, and then I do want to talk about one other, and this is a completely different concept in the sense that we're not talking about the immune system now. We're talking about the same types of cancer, peritoneal carcinomatosis, the nodules that I had showed you before, but a different kind of molecule and different kind of chemical attempts to try to improve surgery. So one thing that you need to know for background purposes is that when we are able to do surgery for patients with this type of cancer, the more of that cancer we remove, the better the patients do over the long run, which kind of stands to reason. If we're able to reduce the number of tumors, they often grow back, but we can slow that way down and sometimes get quite a lot of mileage, years and years for patients that they, would not otherwise have, just by doing a surgery to kind of reduce the amount. We call it cytoreductive surgery, which means to reduce the number of cells, but it's really just kind of a cleanup job. When I talk to patients, I sort of talk to them as if, as a comparison, what it would be like if mold was found in your basement or in your attic or what have you, and you just kind of have to remediate that by going surface by surface, inch by inch, and cleaning each spot up. And the same thing is conceptually true during surgery for this type of cancer, which is that we just have a contamination problem that we have to remediate. So bottom line is, the better we are at seeing those tumors and finding them, the better the surgery is going to be. And I'm going to tell you about a clinical trial that we had run, and not just at Allegheny, but there were 40 patients put on this clinical trial, and I think 20 of them came from Allegheny and were operated on here with our team at West Penn Hospital. And so the name of this chemical, which I won't ask anyone else to pronounce except for myself, is called pegcetacionine. And the interesting thing about this chemical is that it is it forms a nanoparticle, which just means a tiny globule that goes through the bloodstream. And it's composed of different chemical components, but one of the components is a fluorescent dye, like what you would see. You've heard of bioluminescent fish, or aquatic animals that glow in the dark or glow in the water. And of course, everybody's seen fireflies. So it's the same concept, that it is a biological chemical that has an on and off state. So when it's on, it's glowing, it's fluorescing. And when it's off, it just looks like just like a bland yellow color. This chemical was designed to have that on-off switch activated with an acidic or a low pH environment. So in an acid environment, it turns on, and in a base environment, it turns off, or in a normal environment, it turns off. So ordinarily in the body, the pH is kept pretty tightly regulated at about 7.4, which is pretty close to neutral. But in cancerous tissues, the pH is lower because of the way that cancer cells metabolize energy sources. They create acid, and it drops the pH, which means it creates an acid environment. And the idea was that this chemical would go all through the body, but it would only light up or only fluoresce in areas that were an acid pH, including tumors. So the idea was we would give this medication or the drug a couple days before surgery, and then when we went into surgery, you can shine a particular color, like a black light essentially, or a particular wavelength of light that we can use in the operating room. And under that light source, you would see the fluorescence. You would see it glow a different color. So the idea was to do that before one of these big surgeries, to clean out all of these tumor nodules, to see if it helped us identify spots that we wouldn't have seen otherwise. And I'm just going to skip through some of this, but when we do surgery for this type of cancer, it's pretty overwhelming. So we have to divide we divide the abdominal cavity into different regions so that we can keep track of where the tumors were, how many there were, how big they were, and how complete of a job we did of removing all of them. So you don't need to know all of these statistics or all of this background information, only to know that there is a science to how we measure and assess how many tumors there were. And that's how we do it, zone by zone by zone, on the intestines, on the diaphragm, on the liver, etc. So the study design, as I said, was that we would give this medication, and then 24 to 72 hours later, we would do our operation. And the operation, as you can see here, during the operation, we would utilize this wavelength of light that I mentioned to try to detect the fluorescence of the tumors. And you can see that these pictures in the middle here, the one on the left, it's a close-up of a tumor on some fatty tissue in the abdomen, and it's easy and obvious to see, kind of like a radar of a hurricane. You can see right where the activity is. And then on the right half of that picture is a surgeon's hand. It might be mine or one of my partners, holding a piece of intestine, and again demonstrating an area where there was cancer on the intestines. And so that would be an area. Typically, we find most of those just by looking or feeling the tissue with our hands, but you can imagine that that's not perfect. With our eyes are only so good, and sometimes it around a corner or under a surface, you might find an area that you otherwise missed because it's a lot of square footage, believe it or not, to cover in the abdomen between all of the crevices and creases in between the tissues. And then, we would take these areas out along with all the other areas. And the pathologist, one by one would tell us this one had cancer, that one didn't have cancer, this one had cancer, that one didn't have cancer. And we would have kept track, this one lit up and that one didn't light up, and this one lit up and that one didn't. And then we could compare and contrast at the very end how helpful this treatment was in helping the surgeon find extra areas. And so without, again, bogging you down in too much detail, I'm just going to show you a brief video and then go over the summary results. But these are just some additional pictures demonstrating how useful this is in some cases. And so you can see in this upper left panel, there's a piece of intestine. Again, it's in the surgeon's hand. This is the same picture that I showed you before, the one that's lit up, but on the left, you actually get to see what the surgeon is seeing. And so the surgeon is seeing a little tiny spot there, but it wouldn't necessarily be obvious that that was a tumor. And then when you utilize the fluorescence technique, it becomes very obvious that there's a tumor there. And then in the lower left area panel, you see on the left side of that, that's a more obvious tumor. That one we would probably not miss. But again, it's good confirmation to know when the fluorescence is used that it is indeed cancer and that it is needs to be taken out, because we never, we don't want to take out tumors that are, we don't want to take out areas that aren't cancerous. If it's not cancerous, we try to leave it right where it is to reduce the risk for patients, and the side effects of surgery and quality of life gets preserved if we are able to be as precise as possible. And then on the right side, just a couple more examples of the same concept, that it is, it sort of doesn't replace the surgeon's eyes and hands, but it augments them. And so I would just consider this to be an augmentation strategy for the surgeon to detect additional tumors. And this is a brief video here. So if you have if you don't like gory, or if you have a sensitive eye, let me put it that way, you can close your eyes for a minute. But this is a picture during surgery. And what you're seeing here at first is that's one of us holding the intestines. And you can see there's a little bit of activity in the intestines as well. So you have to be careful that you calibrate properly. And that was a lymph node we were feeling before, which can light up a little bit as well. But then this other area that we're going to show here in a second was an area of cancer. And you can see these little nodules that we're feeling there with our fingers are very bright with the fluorescence technique. And they're standing out quite dramatically from the background. And so that's a big red flag for us that those are potentially malignant tumors. And so you'll see us in a second, we remove the tumors using a cautery device. And there's a little bit of bleeding in case you want to shut your eyes for a second. It'll be over soon. Okay, now it's all over. And you can see the empty spot where we removed the tumors. And this is a technique just to burn or obliterate with an electrical cautery device, whatever residual tumors there were there. So that's kind of how we utilize the technology, and we assessed the the helpfulness of it, so to speak, just by saying, when we compare these areas to what the pathologist saw under the microscope, there's pretty good agreement, and that the fluorescence technique had what we call a sensitivity of 84%. So it was about 84% perfect at finding tumors relative to background tissue. And then, we had some other markers that we were looking at, which are a little more I would say a little more just a little bit more technical. But the number that you would really be most interested in is the 50% number at the top, which means that the way that we conducted the study is that we did the operation that we would normally do, and then we turned the camera on after we thought we were done, and we looked for other areas to see if we had missed, or what we had missed, or whether we could find anything else that we hadn't seen with our own eyes. and yeah, that was the sort of the bottom line. So about half the time we were able to find at least one spot that we missed, or either we missed in the sense that we went ahead and took it out after we found it with a second look, or we couldn't take it out, but at least, we were able to document that, well, there was this area that we couldn't take out, but at least we know it's there, and we can put that as part of the record and make treatment plans later if we need to on the basis of that. So in other words, about half the time, about half of patients, this technique was useful in helping us find extra tumors that we weren't necessarily fully aware of. So that study, that trial that I just told you about, was sponsored by a company that produces this drug, and they took the results of the study and went back to the FDA. And as far as I know, they're still working with the FDA. I haven't heard any outcome of that conversation with the FDA, but they have to make the FDA has to sign off on it, on the study and the plan in terms of going forward. And then of course it's a company, so there has to be a business plan, to develop that as something that would be accessible to patients in terms of, a marketed agent that we could buy. We can't get this now because it was only done on a clinical trial, and it's not available for us to use in patients until it goes through those other processes that I mentioned. So that was more or less what I had to say tonight, not to overwhelm you with the details, but really just to say that, surgeons, you're used to thinking of surgeons using instruments, knives, sutures, robots, lasers, etc., to tackle problems. We like to extend that to think about using molecules and chemistry as well. Whatever advantages we can find and leverage, to fight these cancers. We've come as far as we can with conventional treatments, that's for sure. So, we're always looking for ways here at Allegheny to develop newer, smarter techniques to detect and fight these cancers, so that we can improve the lives of our patients and hopefully someday cure these cancers that are many times incurable. So I'm going to stop there, and I see there's one question in the chat, and then anybody else is welcome to chime in as well. The question is from Andrew, and it says, can it be used to suppress inpatient genetically predisposed to those hormones? Yeah, so that's the question about the first clinical trial that I mentioned. So as far as I know, there are no genetically disposed cancers due to IL-6 or an immune marker. Typically, the genetically programmed cancers have to do with things like the body's ability to detect and fix mutations in DNA. And there are other instances or other examples, but not specifically in the immune system. I think when patients have mutations or genetic predispositions to something like IL-6, what we would see in patients like that would be either they would be prone to infections, or they would be prone to autoimmune diseases because they would have they would either have an overactive immune system that was attacking their own normal tissues, or an underactive immune system that was failing to recognize infections usually. Let me see, are there any other questions? I don't see any other questions, but we can hold it open, or
yeah, I think we can leave the chat open for a minute to see if anybody else has anything to chat in for the next minute or two. And then if nothing else comes in, then we'll have Michelle do the wrap up. Oh, here's another question.
Here's another question. Are cancer cells the result of oxidation of free radicals? They're definitely, free radicals are highly reactive chemical species, and I'm not a chemist, so I'm telling you what's in my medical school textbooks, but they are highly reactive forms of chemicals like oxygen and other normal atoms, but they are in a highly reactive format that you can sort of think of as like the kind of thing that would start a chain reaction in a hydrogen bomb or something of that nature. Anyways, when those chemicals collide with or react with DNA, they can cause breakages or mutations to form. And so that is a part of how cancers develop. And it is, and the question about are cancers the result of that? It usually takes more than one thing to put a cancer cell over the top, but that is a well-known contributor. That's one kind of DNA damage. There are other kinds of DNA damage like radiation, UV light. That's why everybody tells you to wear sunscreen. And you know, the normal process where your DNA is replicated in your cells has an error rate, and so there's a whole system to detect those errors and fix them. So anything that disrupts that process or damages DNA can contribute to cancer. So yeah, the answer is yes. It's not the only thing, but it's one of them. Where can you call to see if we fit in the research category? So I can give you my office number if you want. Actually, I'll just type it in the chat here.
Dr. Wagner, I'm not sure they're going to see the chat. The participants are not seeing the chat, but we could have Michelle include that number. If you want to say it, that's fine. But Michelle will send out a follow-up email. We can include that with that as well.
No problem. Yeah, let me just make sure I have it right because I don't use it very often myself.
And it could be 412-578-HOPE is our intake line in general for the Cancer Institute, so we could get directed to you.
You could do that, or I can just give you the direct number to the office.
Okay.
Either way. So the office number is 412-359-3731.
Okay, we'll put that. We'll put in the information that Michelle sends out. Perfect.
All right, and then the question: do we treat uterine cancers? So we have a very active GYN oncology program that I collaborate very closely with, and in fact, many of our clinical trial patients have been ovarian cancer or uterine cancer. So yes, we do treat those cancers, but as you can imagine, with any clinical trial, there are very specific criteria. And so it's very much case by case, but uterine cancer patients are definitely in the group of patients that we treat, depending on, it's usually metastatic cases for my clinical trials. So where with the pattern of cancer is important in those trials. However, there are many other clinical trials available through our GYN oncology service line that would have a specificity for uterine cancer, and so maybe that's a Hope line call or a GYN oncology. If we have the number, we can email that out as well, just in case there's anybody who wants to talk more about our options for uterine cancers. All right, the next question is: I heard that cancer cells cannot develop or survive in a high pH. Yes, so the high pH environment means a base as opposed to an acid or a basic environment. What I understand about it is that it's not so much that cancer cells cannot develop there, it's that cancer cells turn their environment acidic. So the body, our human body, has to stay very tightly regulated normally. So if your pH goes too high or too low, that's an emergency. And your body won't let that happen, no matter how hard you try. So sometimes I read about people staying on an alkali diet or doing things to modify their body's pH, but that is impossible. You can't do it. Your kidneys autocorrect. So no matter how much you try, you could never. I mean, you could do it if you really, really wanted to. I mean, I guess you could overdose on something like that. But in normal day-to-day life, if you were to change your pH, if you were to take an alkali supplement, your body would not let your pH change. It would just simply autocorrect it. If you have too much acid in your body, it gets excreted in your urine or breathed out through the air that you breathe, carbon dioxide. And if you take too much base into your body, the opposite thing happens. The body retains an acid to balance it out or secretes a base. So you can't really alter that. It's very strictly set, and it has to be, because if the pH changes in your body, all of your body's elements like proteins and other chemicals break down. They fail to function. They're designed to function at a very specific pH. So cancer cells can't really change the pH of your entire body. They change the pH of just the local environment where they're in. And the way they do that is they metabolize sugars a little differently than the rest of the body. And so this happens from time to time in normal life as well. If you go for a long run, your muscle tissues are going to metabolize similarly, and there's going to be acid in your muscles, and it's going to have to get washed out in your blood. So if you hear the term lactic acid, that's what that is. And again, your body will not let the overall pH change. If it does, it's an emergency. So your body's going to try to reset that as fast as possible. And if it stays abnormal, you'll become medically ill very, very quickly. That's a big part of what happens when a person will faint or pass out during a marathon or something. They're really struggling to maintain their body's chemical pH. Anyways, bottom line is, I think what cancer cells do is they locally change the acid-base balance, but it's not so much that they can't grow in a basic environment. They grow in a normal environment and turn it abnormal as they grow. All right, so then the next question is, how was an influx of immune cells killing patients with COVID? Okay, so there's the with any virus, there's the virus, what the virus does to directly to the cells, but then there is also the reaction of the body to the virus, and that can sometimes be way out of proportion. So I didn't mean to suggest that the virus itself didn't become deadly. In many patients it did. In a lot of patients, the virus itself created so much problems with breathing that patients were unable to kind of maintain their oxygen. But in other patients, there was that problem, but then there was an extraordinary reaction of the body where their blood pressure would drop and it would become basically like sepsis. And it was, even if the lungs were doing reasonably okay, the rest of the body just crashed. And that's where the immune system kind of overreacted in some ways to the virus. And that happens in other types of viruses too, not just COVID. But that is called something called cytokine release syndrome. And it just means that the immune system has fired on all cylinders, gone way over the top, and it starts crashing the rest of the body's systems, even if the virus itself is held in check or the lungs themselves are okay. It wasn't, it would become dangerous or deadly because of the overreaction. So that's where it's not a dumb question at all. It's a very, very good question. And I only said that because the person who asked it said they were sorry if it was a dumb question, but it's not a dumb question at all. It's actually a very insightful question. The immune cells, it was the immune system kind of overreacting in a not very adaptive way. It was like a shotgun or a machine gun, firing at everything instead of zeroing in on just the virus. And then the next question is about sugar feeding cancer. So that's a really good question too. And I hear a lot about that. Patients who have cancer asking whether they should cut sugar out of their diet. And what I will tell you is that in normal life, your body's tissues and organs use different kinds of fuel for different purposes. So there's sugar or carbohydrates, there's protein in your diet, there's fat in your diet. And at any given time, your body needs all of those things. But some parts of your body will use some of those more than others. For instance, the brain really needs sugar. It feeds off of sugar, believe it or not, or carbohydrates. But the liver is very versatile. It can use many different sources to generate energy. So it is true that cancer cells preferentially require sugar, but so does your brain and so do other organs that are vital organs in your body. So it's not like you can starve the cancer just by cutting sugar out of your body, which is sometimes what you read about internet-based treatments for cancer, is just cutting out sugar in conceptually, it's appealing to think that you could just starve the cancer by cutting sugar out of your body, but you also would starve your brain and your kidneys and your muscles and your heart muscles and other things. So you can't really selectively just affect the cancer cells by cutting sugar out. Hopefully that answers the question, but it is. I wish it were that easy. If we could just cut out sugar. Now, if you have too much sugar and you reduce it, maybe you could make a dent. But I personally, I've seen patients try this, and I have never seen cancer go away as a result of cutting back sugar in the body, sadly. So one day we may find out how to just restrict the cancer cells from using sugar. And if we were able to do that, that could potentially be a game changer.
Thank you, Dr. Wagner. This has been amazing. I mean, Michelle, I don't know if you want to do the wrap up. I don't think I see any other questions. This was a wonderful presentation.
I agree, Margie, and thank you to our audience members for such excellent questions as well. So before we wrap up, if there's no other questions, we would like to thank everybody for attending this evening. And as a reminder, tonight's lecture will be is being recorded. If you're interested in rewatching it or want to share it with your friends or family members, please make sure that you check back on our AHN YouTube channel. In about a week or so, we should have that uploaded. In addition, we also have the Hope Line dedicated to patients calling in for new patient appointments with any one of our specialties. And that number is 412-578-HOPE. And once again, thank you, everybody, for joining us this evening. Have a great night.
Thank you. Good night.
Night.